Alright guys, so this is a technique for treating the sacrotuberous and the sacrospinous ligamentous tissue of your patient. You're going to have your patient lying in a prone position, and I don't want you just to put your hands on their glutes and try and fumble your way around looking for this sacrotuberous sacrospinous ligamentous tissue. A nice, safe way is to start with your hand on their lumbar spine. Get a little bit more specific, working your hands down along the sacrum to the point where you find the sacrococcygeal joint. Now, be really nice and firm here so that there's no miscommunication about what the intent is with your fingers and with your hands. But I want you to sort of assess the sacrococcygeal angle. It should be about 30 degrees. If you find that it's being a little challenging to find the tip of the coccyx, chances are they may have had some type of injury, or they've been through childbirth, or they've had some type of fall on their coccyx that's caused this sacrococcygeal angle to be a little bit more than 30 degrees. I've also had some patients where they've had an increase in pressure develop within the pelvic cavity itself, which has actually pulled the coccyx out away from the pelvic floor. So just be aware of, there's a number of different positions that the sacrococcygeal joint can be in. Some coccyx can actually be rotated one way or the other, and again, depending on if they were in some type of injury or dysfunction, they can also be pivoted one way or the other. So there's rotations, there's deviations. It can sit laterally one side to the other, depending on if it's getting pulled from a number of different structures, or if it's getting pulled anteriorly because of, again, some type of injury or condition. So, starting at the low back, following the sacrum down to the sacrococcygeal angle. Then what I want you to do is I want you to change your position so you match, sort of running parallel with where the sacrotuberous ligament is. I want to take you so that your hand is right underneath the glutes, and I want you to follow along right to the very beginning of that sacrotuberous ligament, right off of the sacrococcygeal proximal sort of attachment. If you go a little bit more lateral, you're going to be into some glutes, external rotators. If you go a little bit more medially, you're going to be into pelvic floor. So I want you to find that taut band of ligamentous tissue that runs from that sacrococcygeal angle down to the ischial tuberosity. Remember that this tissue also blends in and becomes the hamstrings, more so for semitendinosus and semimembranosus, but I want you to really locate where that tendinous portion is. Again, we're going to take our hands nice and straight. We're going to have the thumbs so that they're bridged together, so that they're supporting one another. Thumbs are straight, wrists are straight, elbows are straight. Make sure that you have your table at an appropriate height. And then again, we're going to pay attention to that reciprocal tension of the tissue. We're going to load right into that ligamentous tissue, just taking up the slack a little bit. And we're going to sit and wait. And we're going to wait for a change in densification, an increase in elasticity. We're going to pay attention to our patient's respiration to watch to see if they take short, shallow, sympathetic breaths, if it's really painful or uncomfortable for them, or if it's nice and comfortable for them and it's relaxing and they take a couple of nice, deep parasympathetic breaths. And we're going to just wait until the elasticity comes back into that tissue. From there, we can stop treatment and we can take our hands and our thumbs slowly off of the patient. Or what we can do is we can refocus our direction from the sacrotuberous ligament over to the sacrospinous ligament. Now, these two tissues are essentially the same tissue, but they just have two different attachments. So your finger placement, your thumb placement is going to be at a little bit of a slightly different angle. Instead of accessing sacrotuberous, I want you to come just medially, scoop underneath sacrotuberous, and load towards where the sacrospinous ligamentous tissue is. Now, you're not going to, with some patients, you're not going to be able to get all the way there, but just the intent of redirecting your focus into that fiber direction of that tissue is enough to work with the neurological engagement of that tissue and looking for a ligamental muscular reflex to cause a little bit of a relaxation to the tissues. Again, a ligamental muscular reflex, you're going to get a relaxation to the external rotators, to the glutes, the hamstrings working with these tissues. So just remember, start slow, start at the bottom of the lumbar spine, slowly work your way down to this sacrococcygeal angle. Slowly find where that top band is for the sacrotuberous ligament. Work with the reciprocal tension in this direction. Change your direction to hit the sacrospinous ligamentous tissue. It's going to take a few minutes in order to get a change in the environment to take place through these tissues. So again, when the treatment is completed, don't just pull your fingers off of those structures right away. It took you time to get into those tissues. It should take you a little bit of time to get out of those tissues. It's far more comfortable for the patient the slower that you come out of the treatment techniques. When you're done, that is the technique for sacrotuberous and sacrospinous treatment techniques. So let's see what this looks like with our patient on the table. For the treatment of the sacrotuberous and the sacrospinous ligamentous tissue, you want to have your patient lying in a prone position. The sacrotuberous and the sacrospinous ligaments are very, very strong ligamentous tissues that have connections at the ischial tuberosity into the hamstrings. They also have connections superiorly into the SI ligamentous tissue, and where the erector spinae also come down and interdigitate into the SI ligamentous tissue. You can have sometimes patients will comment on discomfort or pain referral patterns when you engage that tissue, either into the pelvis itself, down the same side hamstring. I've had some patients comment on discomfort going up to the same side erectors or the opposite side erectors, or just right into that iliolumbar ligamentous area. Now, to find the sacrotuberous and the sacrospinous ligamentous tissue, what I want you to do first is find the sacrum, slowly palpate down to the sacrococcygeal joint. Now, if you remember correctly, you need to get informed consent in order to work in through this area, and as I've suggested in previous videos, my informed consent procedures that I started informed consent conversation about 2 to 3 treatments beforehand. Also, you get informed consent the day of, so right at the treatment, at any point in time, they can remove the consent, and then you would stop treatment. But for this angle, for the sacrococcygeal angle, the normal angle should be about 30 degrees. There have been some patients that I've had where the coccyx has been sticking more posteriorly with people such as Annabelle that have landed on their coccyx at some point. Sometimes the tip of the coccyx is very deep inside the pelvis. You sort of have to slowly keep your fingers on the contour of the bone, slide down the bone distally to the very tip of the coccyx. And are we there? I think we're right about there. Mm-hmm. Yep. This is not 30 degrees. This is very much close to a 70-degree sacrococcygeal angle. So at some point in her past, she landed on this coccyx. It shifted into this position and it stayed here ever since. So once you find that sacrococcygeal joint, then if you slowly just work your way a little bit more infralateral, you can actually feel the tension, the tonality of that ligament. If you come more superior and lateral, you'll feel glute medius. If you go more medial and inferior, you're going to be more pelvic floor. We don't want that. We want to stay right on that sacrotuberous ligament. Now, the sacrotuberous ligament runs this way. The sacrospinous ligament runs towards the spine of the pelvis, and they basically are the exact same tissues. You can separate them with a scalpel, but when we've been in the cadaver lab, when we've looked at these, they're essentially side by side, same tissues. One is just a little bit of a different direction than the other. So when it comes time to treat each one individually, you can't really treat them individually. You're going to get them both at the same time, but you can change your hand placement in order to engage more of one than the other, or at least you can try to. So we're going to find sacrum, sacrococcygeal joint, find where that sacrotuberous ligament starts at. I'm going to position myself so that my thumbs are braced against one another, so I'm saving my thumbs, protecting my thumbs. I'm just making contact between the skin and that sacrotuberous ligament for right now. So thumbs are engaged, wrist is engaged, elbows are nice and straight, standing up nice and straight, table's at the right height. And what I want you to do is just slowly load into that tissue, nice and slow, and engage that reciprocal tension of the tissue of this ligamentous tissue. So if I load too deep, too quickly, then we're going to elicit a danger protective mechanism where she's going to contract her glutes, contract her back, contract her hamstrings, and we don't want that. We want to cause a decrease in densification and engagement into this tissue. We want to try and increase an elasticity of this tissue. So just engaging up to that reciprocal tension and waiting for a state change to take place. How are we doing with this?
Okay, a little sharpness, but it's okay.
A little sharp?
Mild, yeah.
Is it diminished at all?
Not yet.
Not yet, okay. So we've got a little bit of a sharpness palpating here. So we're just going to sit at this pressure. We're not going to increase our pressure. We're going to stay at the exact same pressure, respecting the discomfort thresholds and the reciprocal tension of that tissue, of the nervous system. And we're just going to wait for a state change to take place. Slow, deep breath. There's a little bit of a softening that's occurring right now. How are we doing?
Okay. Yeah. Start to ease a bit.
Starting to ease.
I think some of the sharpness might just be where your feet or your hand.
Okay. So I'm going to load a little bit deeper because I've got a little bit more elasticity into this tissue right now. Let's see if I can do this. How are we doing? Doing okay?
Yeah, that's all.
About there?
Yeah.
Okay. It's always good to communicate with your patients. Be aware of what their tolerance level is of that day. It changes from one patient to another, and it changes from one day to day with the same patient. I would encourage you guys to go back to the video on pain referral patterns for the hip and the pelvis, where I go into detail about the pain referral pattern for the sacrotuberous and the sacrospinous ligamentous tissue. Sacrospinous tends to be a little bit deeper than the sacrotuberous, but they have very similar pain referral patterns that can mimic a lot of other dysfunctions. So you really need to run through your diagnostic skills and assessment skills to differentiate between the different referral patterns that are present in the body.
Yeah, I feel the ache in that front area again.
Feeling the ache to the front.
Yeah, a little there.
Do you think that might be a positional issue without having an abdominal pillow?
Maybe. Yeah. It's not like uncomfortable me lying. Generally just flat.
Okay. Well, there's a nice softening that just occurred through the sacrotuberous ligament. So to get to the sacrospinous ligament, you have to go a little bit deeper and sort of scoop underneath the ligament a little bit change your hand position to go more in line of where that sacrospinous fiber direction is, and then load that direction. Does that feel similar or different?
A little different, yeah.
A little different. It's very slight.
Yeah.
So my thumbs really haven't changed drastically from being just off the sacrococcygeal joint into the ligamentous tissue. It's just that I've gone a little bit deeper and I've changed my direction of force to engage more of that sacrospinous ligamentous tissue rather than the sacrotuberous ligamentous tissue. But in reality, we are actually getting both. This is actually softening up quite nicely. I'm getting deeper and deeper. I'm just following the tissue in. Going okay? Okay. I think that's about enough for that one. Okay, so it's taken some time to get into this tissue. I'm going to slowly come out. If you just quickly remove your thumbs, you're going to get a protective mechanism and engagement of the tissue. So slowly removing your thumbs. So this was a technique for Sacrotuberous Sacrospinous ligamentous tissue. Definitely a lot softer onto this side from when we started. What I would encourage you guys to do is to assess bilaterally, assess one side, walk around to the other side of the table, assess this side also, and then depending on which side was the most sensitive and the most lacking in elasticity, had the most densification, I would treat that side. So there's your technique for sacrotuberous and sacrospinous ligamentous tissue.